So guys, we're going to talk about the chest part of FAST today. I know we already talked a bit about that this morning, but we'll go into a little bit more detail. We're going to talk about the techniques of how to go about doing this part of your FAST exam, looking at images and trying to interpret them, and then looking at some of the pitfalls and the limitations when you're doing this type of scan. So there's two parts to this, airway and lung. So we're going to start with airway. So this picture kind of, it's worth 1,000 words in terms of where do you go. So we're going to talk about what transducer do you use and what locations you want to be in. So your trauma patient comes in, obviously they're going to be supine on the gurney. When you want to check where if they're intubated, where their ET tube is, you want to use your high frequency linear transducer and you want to be just at the sternal notch. That's the best place to be able to see the anatomy that you're looking for. Remember to put a little bit of pressure, just like gentle pressure, so you can see the esophagus move out, most commonly to the left. And that way you can see your proper anatomy. And here's a picture of what your anatomy is going to look like. So I'm sure you guys remember this picture from medical school. So here we have a transverse section of the neck. First thing you're going to see, skin and soft tissue, and then you're going to see the muscular layer, very small with the fascia. Then you're going to have your thyroid, your trachea, and then behind is the esophagus. This is what you guys tend to see in medical school. In real life, that's not usually what it tends to look like because the esophagus does move out to the side. So esophagus normally moves to the left, so expect to see that. Here is what that's going to look like for a normal picture. So skin, soft tissue, fascia layer, trachea, air behind, and the esophagus coming out to the left. One of the things you can do to improve this picture, if you can't see it very well, is actually moving to the side. So rocking and coming from the side to look at your trachea and your esophagus, and that way you can get a better visualization of the full anatomy. We're going to do a bit of a case-based way to go through this. So case number 1, a 10-year-old male who was diving and he hit his head. GCS was 7. He had vitals present at the scene. Because of the low GCS, they intubated him, and then he went to VSA. So doing chest compressions when they come into your emerge. And so this is what you see when he was intubated. You put the high frequency linear transducer at his sternal notch. And what do you guys see in this video? That's the beginning. Sorry?
Double trachea.
Double trachea, you're totally right. So initially in this video, we're seeing the trachea here on the right, and on the left, we'll just wait a second, there'll be double trachea. So it looks like 2 tracheas are there. It's not that there's actually 2 tracheas there, it's that you have your ET tube in your esophagus. So it's not for tracheal intubation that you for sure know it's in the trachea, it's that you know that it's not in the esophagus, and that's how you confirm tracheal intubation.
So afterwards they pulled it, right?
Yes, they pulled it out. So it's in, they pulled it out. Now you can see the picture we've seen before of the normal trachea and the normal esophagus. So in terms of our case, they pulled it out, they put it back in, and here they are doing chest compressions. And what do you think now? Single trachea. So yeah, so they put it back into the right place. It's in the trachea. We don't see a second one coming up here. The esophagus is coming out to the side, and so you know this is a tracheal intubation.
Where is this esophagus now?
It's coming out right there. Can I pause this? No, I cannot. Yeah, so it's coming out to the side so that we know that now it's back into the right place. In terms of the child, his vitals came back. He went to the ICU and the CT, had a significant intracranial injury. So we're going to talk about ET tube identification with intubation. So you're going to see this double ring sign in the trachea. So here's our trachea. There's that ring, and then you can see a second ring sometimes there coming through where the air is bouncing back, for lack of a Mark's ping pong word, pinging-ponging back in between each other. So you're going to get your reverberation behind, and you're also going to get your acoustic shadowing behind because the air is reflecting back all of your ultrasound beams. If you go in parallel, supposedly you can see comet tails and a tail sign with it. If it's in the trachea, we don't have any images of that to show you today. If you have both the double ring sign and you have the long parallel signs, and it's 100% sensitive, specific, and has a positive predictive value for the AT tube and the trachea. And this is 49 times faster than getting a chest x-ray or an x-ray of your airway to know where your tube is actually in. So this is a better way to do your, to confirm airway, that your AT tube is in the right place.
Sorry, the comment head and tail is just the ping ponging? Sorry, the second sign is what in addition?
So it's in longitudinal.
Oh, okay.
So yeah, we don't have a picture of
Yeah,
that.
it's in the textbook.
So the other great thing about doing this is you can do it dynamically. So yes, if they come in and they're already intubated, you can check. But the wonderful thing is if you're going to be intubating, as the person running as the TTL or as anyone who's leading the resuscitation, you can actually sit there with your transducer on the neck, a little bit off to the left side, and you know exactly where they're going. And if they're going into the esophagus, you're going to see that double trachea, and then you can tell them to pull out and redirect. So the really good thing is about being able to do it dynamically. And I suggest if you have the opportunity to try doing it that way. Obviously, you can still do it statically, but at least you have immediately if you're in the wrong place. So some of the limitations, if you have subcutaneous emphysema over the neck, you're going to obscure your view. You're not going to be able to see, and that's the same for all lung findings in trauma. The other limitation is if you have something in the esophagus, so like an NG tube, you're not going to be able to know, is this a tracheal intubation or esophageal intubation? And I remember my first case using POCUS for intubation where an NG tube was in, and I was all worried that we had it in the wrong place. All my other signs pointed to it's in the right place, it's in the trachea. And when I looked back, there was an NG tube there, and that's why. So don't be confused by your NG tube, which will mimic the exact same type of thing. The other limitation is you don't know how far deep you are in, and we'll talk about how to figure that out. But this only tells you it's in the trachea or in the esophagus. It doesn't tell you if you're too high or too low. So what do you guys think about this video? We're doing chest compressions. Intubated child. Where's the tube? Esophagus. Awesome. What else could that be? Yeah, perfect. So you guys can see that there. Trachea is here, and then fake trachea over here, so esophagus. Double break sign.
Do you think it looks smaller because the NG is smaller than the NCT?
Not necessarily.